I think the real focus for us on the committee was to bring the voice of the person with MS to the table for building the guidelines. And I don't think I had a chance to say we had wonderful people with MS who on our panel from right at the beginning and helped us think through what were important care issues and what were useful recommendations and what should we really be studying in this guideline. And all the way through the process, they were kind of an important part of what we did and what we delivered. So I think certainly want to emphasize that. Very important. A new thing, we hadn't had that as a standard process in guideline development up until the last few years. So we actually followed the Institute of Medicine recommendations from 2011 for guideline development. And so we really tried to have a very open process, very transparent in terms of conflicts. We didn't have anybody who had a conflict of interest be part of the systematic review, which may differ from some other guidelines. We had two episodes of public review so that anybody could comment on the guideline, and we reached out for people to give commentary. We dealt with all of those comments individually. I spent quite a bit of time on it. We had very professional methodologists, particularly Tamara Pringsheim did unbelievable amounts of work in terms of systematic review, and so I did want to call out her name on the work that she did. So the process was very robust and allowed us to, I think, do the best recommendations we could do with the evidence available. The ones we've heard about in terms of potential pushback, one is a stopping recommendation. The panel felt strongly that there should be some population where medication risks and side effects and burden outweigh the benefit of the treatment. And so we carved out a group of people, rightly or wrongly, that had not been able to walk for 2 years, had not had any signs of immune activation in the past 2 years on treatment, that would be a population one could counsel to stop. And even that, we came to a weak recommendation, meaning we did not achieve consensus. So that was not a strong push to the neurology community to do that. So here's the thing, when you look at the measures of the medications, and if people look at the full document, it has quite a bit of data. The efficacy does seem to differ. However, in an individual going on a long-term medicine for years, what we don't know is there a benefit to going on the most effective medicine early or working your way up there? There's research going on in that area. But we didn't have answers in terms of telling people this is the medicine that all your patients should go on. Okay. And there may be a risk of starting the strongest medicine over time.